Good afternoon, dear students. Today's lecture is devoted to the head, the cranial region, and the trepanation of the skull. The head consists of the brain, its protective coverings, and the ear and face. The cranium, skull, is the skeleton of the head. Learning the features of the cranium serves as an important framework to facilitate the understanding of the head region. The skull consists of flat and irregular bones, is divided into cranial bones, which includes the brain. This part is called neurocranium, and facial bones, which form the bones of the face, or viscerocranium. Here you can see the lateral aspect of the skull, its bones, and anatomical points. In the anatomical position, the cranium is oriented so that the inferior margin of the orbit and the superior margin of the external acoustic meatus of both sides lie in the same horizontal plane. This standard craniometric reference is the orbitomental plane, or Frankfurt horizontal plane. Here you can see it. The cranium consists of two parts, structural and functional, the neurocranium and viscerocranium. The neurocranium, or cranial vault, is the bony case of the brain and its membranous coverings, the cranial meninges. It also contains the proximal parts of the cranial nerves and the vasculature of the brain. The neurocranium has a dome-like roof, the calvaria, or skull cap, and a floor, or cranial base, basicranium. The neurocranium is formed by 8 bones, 4 sinular bones centered on the middle. They are frontal, occipital, sphenoid, ethmoid, and 2 sets of bones occurring as a bilateral pairs, parietal and temporal. The head is divided into 14 regions, 8 of which belong to the face. These regions are frontal region, parietal region, occipital region, temporal region, auricular region, mastoid region, orbital region, infraorbital region, buccal region, parotid region, zygomatic region, nasal region, oral region, and mental region. Here you can see the division of the head into several regions: frontal, parietal, temporal, auricular, and occipital. But usually in Russian anatomical tradition, you can meet the division that includes the single frontal, parietal, occipital region. The face contains the orbital region, infraorbital region, nasal region, oral region, buccal region, and mental region. All of these 14 regions can be grouped into either a neurocranial portion or viscerocranial portion. With the exception of the auricular region, which includes the external ear, the names of the region of the neurocranial portion of the head correspond to the underlying bones or bony features, and they are the frontal, parietal, occipital, temporal, and mastoid regions. The soft tissue enveloped of the cranial vault is called the scalp. The scalp extends from the external occipital protuberance and superior nuchal lines to the supraorbital margins. The scalp consists of 5 layers: the skin, connective tissue, epicranial aponeurosis, loose areolar tissue, and pericranium. The first 3 layers are bound together as a single unit. The single unit can move along the loose areolar tissue over the pericranium, which is adherent to calvaria. Here on this picture you can see the layers of the frontoparietal occipital region. Let's discuss the layers of the scalp one by one. Skin. The skin of the scalp is thick and hair-bearing and contains numerous sebaceous glands. As a result, the scalp is a common site for sebaceous cysts. Connective tissue or superficial fascia. The superficial fascia is a fibrofatty layer that connects skin to the underlying aponeurosis of the occipita frontalis muscle and provides a passageway for nerves and blood vessels. Blood vessels are attached to this fibrous connective tissue. If the vessels are cut, this attachment prevents vasospasm, which could lead to profuse bleeding after injury. Then, the epicranial aponeurosis or glea aponeurotica. The epicranial aponeurosis is a thin, tendinous structure that provides an insertion site for the occipita frontalis muscle. Posterolaterally, the epicranial aponeurosis attachment extends from the superior nuchal line to the superior temporal line. Laterally, the epicranial aponeurosis continues as the temporal fascia. Anteriorly, the subaponeurotic space extends to the upper eyelids due to the lack of a bony insertion. This loose areolar tissue provides a potential subaponeurotic space that allows fluids and blood to pass from the scalp to the upper eyelids. Areolar tissue loosely connects the epicranial aponeurosis to the pericranium and allows the superficial 3 layers of the scalp to move over the pericranium. Scalp flaps are elevated along the relatively avascular plane in craniofacial and neurosurgical procedures. However, certain emissary veins traverse this layer, which connects the scalp veins to the diploic veins and intracranial venous sinuses. Pericranium. The pericranium is the periosteum of the skull bones. Along the suture lines, the pericranium becomes continuous with the endosteum. A subperiosteal hematoma, therefore, forms the shape of the skull bones. Occipitofrontalis muscle. The occipitofrontalis muscle consists of 2 occipital bailies and 2 frontal bailies. The occipital bailies arise from the superior nuchal lines to the occipital bone. The frontal bailies originate from the skin and superficial fascia to the upper eyelids. The occipital and frontal bailies insert into the epicranial aponeurosis. Each occipital bailey is innervated by the posterior auricular branch of the facial nerve, and each frontal bailey is innervated by the frontal branch of the facial nerve. The frontal bailies can raise the eyebrows. Nerve supply. The following 6 sensory nerve branches of either the trigeminal nerve or the cervical nerve supply the scalp. On this picture, you can see those nerves. The anterior aspect of the calvaria is supplied by supratrochlear nerve, supraorbital nerve, and a small side by zygomatica temporal nerve. Lateral aspect is supplied by auriculotemporal nerve, and posterior or occipital part is supplied by the lesser occipital nerve and the greater occipital nerve. The right half of the picture is presented by the arteries that form the vasa nervus bundles of the calvaria, and among them we can meet supratrochlear artery and supraorbital artery, and also zygomatica temporal artery. Those arteries come to the frontal part of the calvaria, or regio fronta parieta accipitalis in particular. The lateral aspect is supplied by superficial temporal artery, and posterior or occipital aspect is supplied by the posterior auricular artery that passes independently, and the occipital artery that form the vasa nervus bundle. Supratrochlear nerve, a branch of the ophthalmic division of the trigeminal nerve. This nerve supplies the scalp in the medial plane at the frontal region, up to the vertex. Supraorbital nerve, also a branch of the ophthalmic division of the trigeminal nerve. This nerve supplies the scalp at the front, lateral, and supratrochlear nerve distribution up to the vertex. Zygomatico-temporal nerve, a branch of the maxillary division of the trigeminal nerve. It supplies the scalp over the temple region. Auriculotemporal nerve, a branch of the mandibular division of the trigeminal nerve. It supplies the skin over the temporal region of the scalp. Lesser occipital nerve, a branch of the cervical plexus, C2. It supplies the scalp over the lateral occipital region. And the greater occipital nerve, a branch of the posterior ramus of the second cervical nerve. It supplies the scalp in the median plane at the occipital region up to the vertex. On this picture you can see the division of three portions of the trigeminal nerve that supply different parts of the head. As you can see, the superior third of the face and the frontal part of the calvaria are supplied by the first portion of the trigeminal nerve, or the branches of the ophthalmic nerve. The middle third of the face is supplied by the branches of the maxillary nerve, the second portion of the trigeminal nerve. And the inferior third of the face, the temporal region, and the parietal part of the regio fronta parieta accipitalis are supplied by the third portion of the trigeminal nerve. This is the mandibular nerve. The frontal branch of the facial nerve supplies the frontal balis of the occipita frontalis muscle, and the auricular branch of the facial nerve supplies the occipital balis of the muscle. The scalp has a rich vascular supply. The blood vessels traverse the connective tissue layer which receives vascular contribution from the internal and external carotid arteries. The blood vessels anastomose freely in the scalp. Wounds in the scalp bleed profusely because the fibrous fascia prevents vascular constriction. However, the wounds superficial to the aponeurosis gap much less than do wounds that cut through it, because aponeurosis holds the skin tight. During a difficult birth, bleeding may occur between the neonates pericranium and calvaria, usually over the first parietal bone, because of a rupture of the multiple minute periosteal arteries. The resultant collection of blood several hours later and after birth is known as a cephalohematoma. Anastomosis exists at the medial angle of the eye, between the facial branch of the external carotid artery and the cutaneous branch of the internal carotid artery. During old age, if the internal carotid artery undergoes atherosclerotic changes, the intracranial structures can receive blood from the connection of the facial artery to the dorsal nasal branch of the ophthalmic artery. From the midline anteriorly, the arteries present as follows: supratrochlear artery, supraorbital artery, superficial temporal artery, posterior auricular artery, and occipital artery. Here you may see the picture once again that contains both the nerves of the calvaria and the arteries of the calvaria. The supratrochlear and supraorbital arteries are two branches of the ophthalmic artery, which in turn is a branch of the internal carotid artery. These arteries accompany the corresponding nerves. The superficial temporal artery is a terminal branch of the external carotid artery that ascends in front of the auricle. This artery, which supplies the scalp over the temporal region, travels with the auricular temporal nerve and divides into anterior and posterior branches. The posterior auricular artery is a branch of the external carotid artery that ascends posterior to the auricle. The occipital artery is a branch of the external carotid artery. It is accompanied by the greater occipital nerve. The veins of the scalp freely anastomose with one another and are connected to the diploic veins of the skull bones and the intracranial dural synosis through several emissary veins. The emissary veins are valveless. The emissary veins do not have valves and open in the loose areolar tissue. Therefore, infection can be transmitted from the scalp to the cranial cavity. This layer of loose areolar tissue is known as the dangerous area of the scalp. Venous and lymphatic drainage. The scalp veins, which are as follows, accompany the arteries and have similar names. Supratrochlear and supraorbital veins drain the anterior region of the scalp. These two veins unite to form the angular vein and the medial angle region of the eye and continue further as the facial vein. Superficial temporal vein descends in front of the auricle and enters the parotid gland. It joins the maxillary vein to form the retromandibular vein, the anterior division of which unites with the facial vein to form the common facial vein, which then drains into the internal jugular vein. Posterior auricular vein joins the posterior division of the retromandibular vein to form the external jugular vein. The occipital vein terminates in the suboccipital venous plexus, which lies beneath the floor of the upper part of the posterior triangle. The part of the scalp that is anterior to the auricles is drained into the parotid, submandibular, and deep cervical lymph nodes. The posterior part of the scalp is drained into the posterior auricular or mastoid and occipital lymph nodes. Here you can see the scheme of the lymphatic drainage of the calvaria and different groups of the lymphatic nodes that receive lymph from it. Meninges. The meninges consists of three tissue layers that cover the brain and spinal cord. They are the pia, the arachnoid, and the dura mater. The pia along the arachnoid are referred to as the leptomeninges, whereas the dura is referred to as the pachymeninx. Here you can see uh, the illustration, the picture that demonstrates us the meninges, cranial dura mater, arachnoid, and pia mater. The outermost meningeal layer is the dura mater, which lines the inferior of the skull. The dura mater is composed of two individual layers, the meningeal dura and the periosteal dura. For the most part, these layers are fused. Venous sinuses can be found in areas of separation. The tentorium cerebelli is a dura mater fold that separates the cerebellum from the cerebrum. The falx cerebri is a fold that separates the left and right cerebral hemispheres. Dural venous sinuses endothelial line spaces between the outer periosteal and inner meningeal layers of the dura mater, into which empty the cerebral veins. The cerebellar veins and the veins draining the brainstem, and the lead of the internal jugular veins. Here you can see the illustration, the scheme of all the venous sinuses of the dura mater. The innermost of the three layers is the pia mater, which tightly covers the brain itself, conforming to its grooves and folds. This layer is rich with blood vessels that distend into the brain. Outside the pia mater, which tightly contours the brain, is the arachnoid mater. The arachnoid mater is a thin, web-like layer. Between the pia mater and the arachnoid mater is a space called the subarachnoid space, which contains the cerebrospinal fluid. This space is where the major arteries supplying blood to the brain lie. If a blood vessel ruptures in this space, it can cause a subarachnoid hemorrhage. Between the arachnoid mater and the dura mater is the subdural space. If bleeding occurs in the space underneath the dura mater, it is called subdural hematoma. If bleeding occurs outside the dura but underneath the skull, this is called the epidural hematoma. This picture shows us the epidural hematoma that arises between the fractured skull bone and the external layer of the dura mater. The etiology of this hematoma is the ruptured vessel. It's rather dangerous situation that requires the immediately surgery. Arterial supply of the dura. The dura is supplied by three groups of arteries. Anterior meningeal artery are branches of ethmoidal arteries, which are branches of maxillary artery. As you remember, the maxillary artery is the terminal branch of the external carotid artery. The middle meningeal artery, an accessory meningeal artery, are also the branches of the maxillary artery. It is also the pool of the external carotid artery. And posterior meningeal artery, terminal branch of ascending pharyngeal artery, and other meningeal branches, smaller meningeal branches from the ascending pharyngeal artery, occipital artery, and vertebral artery. This picture demonstrates us the veins of the brain. And as we just know, the veins of the brain empty to the venous sinuses of the dura mater. The brain is best in cerebrospinal fluid, which is continuously produced and absorbed. The ventricles are cerebrospinal fluid containing cavities within the brain. The structures that produce cerebrospinal fluid are contained within the ventricles and are called the choroid plexuses. This is the scheme of circulation of the cerebrospinal fluid. Cerebrospinal fluid is produced at the rate about 450 milliliters per day, although at any given time about 150 milliliters can be found within the cerebrospinal fluid spaces. Thus, the volume of the cerebrospinal fluid in most adults is turned over about 3 times per day. The brain has 4 ventricles. Within the cerebral hemispheres are the lateral ventricles, which are connected to each other and to the third ventricle through a pathway called the intraventricular foramen, or the foramen Monro, according to Otto, of course. The third ventricle lies in the midline, separating deep brain structures such as the left and right thalami. The third ventricle communicates with the fourth ventricle through the cerebral aqueduct, or aqueduct of Sylvius, which is a long, narrow tube. This is the system of ventricles of the brain. Ventricular system, which circulates cerebrospinal fluid through brain. From the fourth ventricle, cerebrospinal fluid flows into the subarachnoidal space around both the brain and the spinal cord. From the subarachnoid space, cerebrospinal fluid is then absorbed into the venous system. Arachnoid granulations of villi are structures projecting into the superior sagittal sinuses that release cerebrospinal fluid back into the venous system. Hydrocephalus is a condition in which production of cerebrospinal fluid is disproportionate to absorption. This is most commonly caused by impaired absorption resulting from obstruction of the cerebrospinal fluid circulatory pathways, in which case it is termed obstructive hydrocephalus. This also occurs when the absorption of the cerebrospinal fluid is impaired, in which case it is termed communicating hydrocephalus. Rarely is hydrocephalus caused by increased cerebrospinal fluid production. Arteries supply blood to the brain via 2 main pairs of vessels, the internal carotid artery and the vertebral artery on each side. The internal carotid artery on each side terminates into the anterior cerebral artery, the middle cerebral artery, and the posterior communicating artery. The vertebral arteries on each side join to form the basilar artery. The basilar artery then gives rise to the posterior cerebral arteries and the superior cerebellar arteries. The basilar artery, the posterior cerebral arteries, the posterior communicating arteries, and the anterior cerebral arteries, along with the anterior communication artery, form an important collateral circulation at the base of the brain termed the cerebral arterial circle of Willis. These vessels lie within the subarachnoid space and are a common location of cerebral aneurysms to form. Venous return to the heart occurs through a combination of deep cerebral veins and superficial cortical veins. The veins then contribute to larger venous sinuses, which lie within the dura and ultimately drain through the internal jugular veins to the brachiocephalic veins and then into the superior vena cava. Superior sagittal sinus laid open after removal of the skull cap. The Hordevilisi are clearly seen. The venous lacuna are also well shown. From two of them, probes are passed into the superior sagittal sinus. Now we will talk about the sinuses of the dura mater. The sinuses of the dura mater are venous canals which drain the blood from the brain. They are devoid of valves and are situated between the two layers of the dura mater and lined by endothelium continuous with that which lines the veins. They may be divided into two groups. The first one, a posterior superior, at the upper and back part of the skull, and the second group, an anterior inferior, at the base of the skull. The posterior superior group comprises the following sinuses: superior sagittal, straight, inferior sagittal, two transverse, and occipital. Once again, superior sagittal, straight, inferior sagittal, two transverse, and occipital. You can see 5 positions. The superior sagittal sinus, in Latin sinus sagittalis superior, or superior longitudinal sinus, occupies the attached of convex margin to the falx cerebri, commencing at the foramen caecum, through which it receives a vein from the nasal cavity. It turns from the before backward, grooving the inner surface of the frontal, the adjacent margins of the parietals, and the superior division of the cruciate eminence of the occipital. Near the internal occipital protuberance, it deviates to one or other side, usually the right, and is continued as the corresponding transverse sinus. It is a triangular in section, narrow in front, and gradually increases in size as it passes backward. Its inner surface presents the openings of the superior cerebral veins, which run from the most part obliquely forward and open chiefly at the back part of the sinus, their orifices being concealed by fibrous folds. Numerous fibrous bands, Hordevilisi, extend transversely across the inferior angle of the sinus, and lastly, small openings communicate with irregularly shaped venous spaces, venous lacuna, in the dura mater near the sinus. There are usually 3 lacuna on either side of the sinus: a small frontal, a large parietal, and an occipital, intermediate in size between the other two. The most of the cerebral veins from the outer surface of the hemisphere open into these lacuna, and numerous arachnoid granulations. Granulations are called Pacchionian bodies. Project into them below. The superior sagittal sinus receives the superior cerebral veins from the deep layer and dura mater, and near the posterior extremely of the sagittal suture. Veins from the pericranium, which pass through the parietal foramina. Dura mater and its processes exposed by removing part of the right half of the skull and the brain. The inferior sagittal sinus is contained in the posterior half or 2/3 of the 3 margin of the falx cerebri. It is of a cylindrical form, increases in size as it passes backward, and ends in the straight sinus. It receives several veins from the falx cerebri and occasionally a few from the medial surface of the hemispheres. The straight sinus, sinus rectus, tentorial sinus, is situated at the line of junction of the falx cerebri with the tentorium cerebelli. It is triangular in section. increases in size as they proceeds backward, and runs downward and backward from the end of the inferior sagittal sinus to the transverse sinus of the opposite side, to that into which the superior sagittal sinus is prolonged. Its terminal part communicates by a cross branch with the confluence of sinuses. Besides the inferior sagittal sinus, it receives the great cerebral vein, the great vein of Galen, and the superior cerebellar veins. A few transverse bands cross its inferior. Here you can see the sagittal section of the skull showing the sinuses of the dura. Tentorium cerebelli from above. The sinuses at the base of the skull. Then we will talk about transverse sinuses. In other words, sinus transversus in Latin, or lateral sinuses, are of large size and begin at the internal occipital protuberance. One, generally the right, being the direct continuation of the superior sagittal sinus, the other of the straight sinus. Each transverse sinus passes lateralward and forward, describing a slight curve with its convexity upward to the base of the petrous portion of the temporal bone, and lies in this part of its course in the attached margin of the tentorium cerebelli. It then leaves the tentorium and curves downward and medialward to reach the jugular foramen, where it ends in the internal jugular vein. In its course, it rests upon the squama of the occipital, the mastoid angle of the parietal and mastoid part of the temporal, and just therefore its termination. The jugular process of the occipital, the portion which occupies the groove on the mastoid part on the temporal, is sometimes termed the sigmoid sinus. The transverse sinuses are frequently on unequal size, that formed by the superior sagittal sinus being the larger. They increase in size and they proceed from behind forward. The petrosquamous sinus, when present, runs backward along the junction of the squama and petrous portion of the temporal and opens into the transverse sinus. The occipital sinus, sinus occipitalis, is the smallest of the cranial sinuses. It is situated in the attached margin of the falx cerebri and is generally single, but occasionally there are two. It commences around the margin of foramen magnum by several small venous canals, one of which joins the terminal part of the transverse sinus. It communicates with the posterior internal vertebral venous plexuses and ends in the confluence of the sinuses. The confluence of the sinuses, in Latin confluens sinum, or torcular heraphili, is the term applied to the dilated extremity of the superior sagittal sinus. It is of irregular form and is lodged on one side, generally the right, of the internal occipital protuberance. From it, the transverse sinus of the same side is derived. It receives also the blood from the occipital sinus and is connected across the midline with the commencement of the transverse sinus of the opposite side. The next group of the sinuses, the antero-inferior group. It includes two cavernous, two superior petrosal, two intracavernous, two inferior petrosal, and basilar plexus. The cavernous sinuses, sinus cavernosus, are so named because they present a reticulated structure due to their being traversed by numerous interlacing filaments. They are of a regular form, larger behind than in front, and are placed one on either side of the body of the sphenoid bone, extending from the superior orbital fissure to the apex of the petrous portion of the temporal bone. Each opens behind into the petrosal sinuses. On the medial wall of each sinus is the internal carotid artery, accompanied by filaments of the carotid plexus. Near the artery is the abducent nerve. On the lateral wall are the oculomotor and trochlear nerves, and the ophthalmic and maxillary divisions of the trigeminal nerve. These structures are separated from the blood, flowing along the sinus by the lining membrane of the sinus. The cavernous sinus received the superior ophthalmic vein through the superior orbital fissure, some of the cerebral veins, and also the small sphenoparietal sinus, which courses along the under surface of the small vein of the sphenoid. It communicates with the transverse sinus by means of the superior petrosal sinus, which the internal jugular vein through the inferior petrosal sinus, and a plexus of veins on the internal carotid artery, which with the pterygoid venous plexus through the foramen vesali, foramen ovale, foramen lacerum, and with the angular vein through the ophthalmic vein. The two sinuses also communicate with each other by means of the anterior and posterior intracavernosus sinuses. Here is the scheme that demonstrates the cavernous sinus, its walls, and the anatomical structures pass through it. Among them, as you already know, the internal carotid artery, the oculomotor nerve, trochlear nerve, ophthalmic nerve, abducent nerve, and maxillary nerve. And pay attention that sphenoidal sinus from the groups of nasal sinuses that is fulfilled by the ear is near the cavernous sinuses. It's separated from it by a thin bony plate. It has its clinical meaning in case of any purulent processes within the sphenoidal sinus. The intracavernous sinuses, sini intracavernosi, are two in number, an anterior and a posterior, and connect the two cavernous sinuses across the midline. The anterior passes in front of the hypophysis cerebri, the posterior behind it, and they form with the cavernous sinuses a venous circular sinus around the hypophysis. The anterior hypophysis, I mean pituitary gland. The anterior one is usually the larger of the two, and one or other is occasionally absent. The superior petrosal sinus, sinus petrosus superior, small and narrow, connects the cavernous with the transverse sinus. It runs lateralward and backward from the posterior end of the cavernous sinus over the trigeminal nerve and lies in the attached margin of the tentorium cerebelli and in the superior petrosal sulcus of the temporal bone. It joins the transverse sinus where the later curves downward on the inner surface of the mastoid part of the temporal. It receives some cerebellar and inferior cerebral veins and veins from the tympanic cavity. The inferior petrosal sinus, sinus petrosus inferior, is situated in the inferior petrosal sulcus, formed by the junction of the petrosal part of the temporal with the basilar part of the occipital. It begins in the posterior inferior part of the cavernous sinus and passing through the anterior part of the jugular foramen, ends in the superior bulb of the internal jugular vein. The inferior petrosal sinus receives the internal auditory veins and also veins from the medulla oblongata, pons, and undersurface of the cerebellum. The exact relation of the parts to one another in the jugular foramen is as follows. The inferior petrosal sinus lies medially and anteriorly with the meningeal branch of the ascending pharyngeal artery and is directed obliquely downward and backward. The transverse sinus is situated at the lateral and back part of the foramen, with a meningeal branch of the occipital artery, and between the two sinuses are the glossopharyngeal, vagus, and accessory nerves. These three parts of structures are divided from each other by two processes of fibrous tissue. The junction of the inferior petrosal sinus with the internal jugular vein takes place on the lateral aspect of the nerves. The basilar plexus, plexus basilaris, transverse of basilar sinus, consists of several interlacing venous canals between the layers of the dura mater over the basilar part of the occipital bone and serves to connect the two inferior petrosal sinuses. It communicates with the anterior vertebral venous plexus. Emissary veins, vena emissaria. As about the emissary veins, they pass through the apertures of the cranial wall and establish communications between the sinuses inside the skull and the veins external to it. Some are always present, others only occasionally so. The principal emissary veins, they are: the first one, a mastoid emissary vein, usually present, runs through the mastoid foramen and unites the transverse sinus with the posterior auricula or with the occipital vein. Second one, the parietal emissary vein, passes through the parietal foramen and connects the superior sagittal sinus with the veins of the scalp. And third, a network of minute veins, rete canalis hypoglossi, traverses the hypoglossal canal and joins the transverse sinus with the vertebral vein and deep veins of the neck. The fourth, an inconstant condyloid emissary vein, passes through the condyloid canal and connects the transverse sinus with the deep veins of the neck. Fifth, the network of veins, rete foraminis avalis, unites the cavernous sinus with the pterygoid plexus through the foramen avalia. Sixth, two of these small veins run through the foramen lacerum and connect the cavernous sinus with the pterygoid plexus. Seventh, the emissary vein of the foramen of Vesalius connects the same parts. Eighth, an internal carotid plexus of veins traverses the carotid canal and unites the cavernous sinus with the internal jugular vein. Ninth, a vein is transmitted through the foramen cecum and connects the superior sagittal sinus with the veins of the nasal cavity. We should know the emissary veins because they may be the pathways for the pus, which may spread and initiate the intracranial complications. Hemorrhage of the brain, epidural hematoma. In this scheme, it's shown that usually as sources of the epidural hematoma, as the reasons of the epidural hematoma are the ruptures or lesions of arteries. The middle, usually these are the branches of the middle meningeal artery, usually due to blow to the inside of the head at the pterion, area where skull is thinnest, easiest to fracture. And fracture may rupture the anterior branch of the middle meningeal artery. And subdural hematomas. Usually veins are guilty in such kinds of hematomas, tears in bridging veins that cross the subdural space. The term meningitis, the inflammation of the meninges, pera, arachnoid of the brain or spinal cord or both. let's discuss the trepanation of the skull. Trepanation of the skull requires to have special neurosurgical instruments. They are trepan with the set of the cutters, wire saw of Jiggly, conductor of Polenov, bone scissors of Dahlgren, and a lure, raspatory, spoons for scooping, meningeal scissors, and others. Two types of trepanation are distinguished. They are osteoplastic and resectional. During osteoplastic trepanation, osteoperiosteal flap is cut out, which is replaced at the end of the operation. During resectional trepanation, osteoperiosteal flap is removed, and this results in different calvarium bones. Defect of the calvarium bones. Here you can see the instruments for the skull trepanation. The surgical excess is chosen in the site where pathological focus is closest to the calvarium. The line of the incision is chosen according to the Cronlane scheme. Pathological focus has to be projected on the center of the trepanation opening. Its size is usually 10 or 12 centimeters. Skin incision is usually tongue-shaped with its base faced downwards and is made along the course of main brain arteries. Osteoplastic trepanation of the skull. Indications: tumors of the brain, hematoma, cyst, edema of the brain, and some others. Techniques of the operations. Skin, subcutaneous fat, and epicranial aponeurosis are cut with scalpel, thus forming horseshoe-shaped incision with its base face downwards. Hemostasis from the vessels of the subcutaneous fat is performed by ligation with bite of electrocoagulation. On this picture you can see different steps of the osteoplastic skull trepanation. The flap is turned aside and periosteum is exposed. It is also cut with semilunar incision stepping back from the wound, ages 1 or 2 centimeters. Periosteum is removed with raspatory, thus forming the outlines of future osteoplastic flap. 5 or 6 cutter openings are marked with 5 or 6 centimeters interval between them. First, the dipping in the bone is made with the spear-shaped cutter. Then spear-shaped cutter is replaced by the cone-shaped cutter. The last millimeters of the opening are made with a watermelon cutter. When the cutter reaches the hyaloid membrane, it is necessary to stop drilling and remove it with bone spoon or pincers. The part of the bone between the openings is sewn with wire saw of jiggly, different kinds of transcription. In order to conduct the saw from the one opening into the other, guide of Polenov is used, which is conducted between the dura mater and flat bones of the skull. Then the conductor is taken away, the handles are put on the saw, and bone is sewn in such a way that osteoperiosteal flap becomes bevel and doesn't fall in while being replaced. Instead of the saw, bone scissors of Dahlgren may also be used. So, cutter openings are connected between themselves while the base of the osteoperiosteal flap is left intact. The edge of the flap is elevated with the elevator and carefully cracked at the base. The hemorrhage from the diploitic veins and emissaries is stopped with wax paraffin paste, which is rubbed into the edges of the saw cut. Dura mater is examined. Normally it pulsates. In pathology, there is no pulsation due to great tension. In order to decrease the intracranial pressure, the performance of lumbar puncture with removal of 30 or 40 milliliters of liquor is strongly indicated. In case the puncture is not performed, strangulation of brain tissue may occur during the dissection of dura mater. Dura mater is opened with meningeal scissors, thus forming the horse-shaped incision stepping 1 centimeter back from the bone edge in order to lighten the subsequent stitching of a wound. The tumor, hematoma, or any other pathological processes are removed. Dura mater is stitched with the nodular or uninterrupted suture. Osteoperiosteal flap is placed back. The wound is taken in stitches layer by layer. It was the description of the technique of the osteoplastic trepanation. And now we turn to the decompression trepanation of the skull. And indications for the decompression trepanations are inoperable tumor of the brain, irresectable tumor of the brain, that led to the extremely increased intracranial pressure. Usually this tumor quickly progressing, or it may be incurable edema of the brain. The principle of the operation lays in performance of defect in flat bone of the skull, which results in decompression. In case of the tumor, the trepanation window is formed right above it. If the diagnosis is not clear, the window is formed in the right temporal area in right-handed persons and in the left temporal area in left-handed persons, in order to prevent possible speech disturbance while bludgeoning of the brain into the opening. Horseshoe shaped incision with its base face downwards is formed in the temporal area. Proper fascia and temporal muscle are cut out along the course of the muscular fibers. The periosteum is exposed. The periosteum in the projection of the future trepanation opening is removed with raspatory. Here is the scheme of the decompressive trepanation. Those trepanations, I mean osteoplastic, both osteoplastic and decompressive, are called after authors who described and firstly used it. The osteoplastic trepanation is known as the trepanation by Oliver Crone, and the decompressive trepanation is known as trepanation by Cushing. Then, Carter opening is performed taking into consideration the course of the middle meningeal artery. Then the opening is enlarged till the size from 5 to 6 centimeters with bone scissors or fluid. In order to decrease intracranial pressure, lumbar puncture is performed. Dura mater is dissected with cross-shaped incision. The wound is taken in stitches layer by layer. We should tell a few words about the surgical treatment of the skull wounds. All cranial cerebral wounds are divided into penetrating and non-penetrating ones. That depends on the involvement of the dura mater. It is injured, if it is injured, we deal with penetrating wound. If it is not injured, we treat non-penetrating wound. Patients with cranial-cerebral injuries have to be surgically treated urgently. The terms of primarily surgical treatment of craniocerebral wounds is more than terms for the wounds of the extremities, because the tissues of the head have better blood supply and are more resistant to the infection. Thus, primarily surgical treatment of the wounds of the head performed within first 3 days is attributed to the early primarily surgical treatment, and within 4 or 6 days to delayed primary surgical treatment. If surgical treatment is performed later than 6 days, it is attributed to late primary surgical treatment. X-ray imaging allows revealing of foreign bodies and specifying its localization. 0.5% solution of Novocaine is used for local infiltration anesthesia. The hairs are shaven, the head is washed with warm water and soap, the skin is cleansed with liquid ammonia. If the skin is very dirty, it is cleansed with a gasoline or alcohol, and then with iodine. The edges of the wound are cut with border incisions stepping back 0.5 centimeters. Necrotizing tissues, clots of blood and foreign bodies are removed. Soft tissues are cleansed with a 3% solution of hydrogen peroxide. If the bone is injured, freely lying fracture fragments are removed. Fracture fragments covered with periosteum have to be left in the wound. They will adhere to the skull, will probably adhere. If open fractures, it's necessary to examine dura mater in order to reveal its injuries. It may require enlargement of bone defect with bone scissors or luer till the necessary size. The edges of the defect are avernate. Dura mater is examined. If it's not injured and there is no hematoma in it, dura mater pulsates. In such case, it is not treated in order to prevent the penetration or of infection, but only cleansed with a stream of sterile physiological solution. If dura mater is injured, then it is tense, it doesn't pulsate, and we see hematoma. In such a case, it's necessary to try to make a puncture, to punctate the hematoma with a syringe. If it is impossible due to the blood coagulation, dura mater is dissected with a linear or cross-shaped incision. Clots of blood are removed with sterile physiological solution and gauze balls. The injured vessels is found and ligated. Dura mater is taken in stitches hermetically. If the wound is penetrating, bone fragments and foreign bodies are carefully removed from the brain substance. Wound canal running through the brain substance may be drained in the following way. The patient under local anesthesia is asked to cough when the surgeon squeezes patient's jugular veins. At least an increase of intracranial pressure, and it pushes out foreign bodies from the wound canal. In more severe cases, it's possible to carefully enlarge brain wound with narrow brain spatula or probe of the canal with light bulbous and probe of with finger in order to take foreign body with pincers and remove it. It is not allowed to cleanse dura mater and brain substance with solutions of antibiotics because they have irritating impact on the centers of the cortex. The edges of the injured dura mater are excised minimally. Defects are closed hermetically. Different methods of plastics are used, for example, cutting out of the flap in the neighbor area using the two-layered structure or application of the fibrin membrane. During primary surgical treatment of the skull wounds, it's necessary to pay special attention to the methods of hemostasis in different tissues. Hemorrhage from the external tissues of the skull are stopped by applications of vascular clamps, electrocoagulation, ligation with bite. In case of hemorrhage from diploic veins or flat bones of the skull, wax paraffin paste is rubbed into the bone cut. In case of injury of the vessels of dura mater, it is not allowed to use the electrocoagulation because it results in corrugation of dura mater and scar formation. In such cases, the vessels are stitched and ligated, or clips are applied on the injured ends of the vessels. Serious complication is bleeding from the injured sinus. Linear wounds of the upper wall of the sinus may be stitched with nodular stitches or are tamponed with hemostatic sponge. In case of significant injuries of the sinus, the only possible way of treatment is its ligation. Silk ligatures are conducted with big round needle under the sinus base, and sinus is ligated anteriorly and posteriorly from the place of its injury. It should be kept in mind that a ligation of sinus may result in disturbances of venous flow out with all consequent complications. Injury of confluence of sinuses results in fatal outcome. Hemorrhage from the brain vessels is stopped by electrocoagulation, ligation, and application of hemostatic sponge or tampons saturated with 3% hydrogen peroxide. My dear friends, we've discussed all the aspects of the clinical anatomy of the skull and the skull trepanation for today. Thank you very much for the attention. See you next time. Goodbye.